So I'd like to introduce Dr. Ezzat. We all know he's, very much world-renowned endocrinologist, and he's involved in a lot of stuff going on within Canada, plus outside of Canada, which is awesome for acromegaly and gigantism. Dr. Ezzat obtained his medical degree from the University of Manitoba and completed his residential training at the University of British Columbia and did postdoctoral and research training in molecular oncology at the UCLA School of Medicine in Los Angeles. Dr. Ezzat's research program focuses on the genetics and epigenetics of the neuroendocrine development and tumorigenesis. He teaches a number of courses including physiology, biochemistry, and development biology of neuroendocrinology. He has published more than 280 original research articles and contributed 40 invite book chapters and reviews on endocrine oncology. He has given over 200 invite lectures to national and international scientific audiences and has received many awards from the national and international scientific and other organizations, including the 2014 Maureen Coleman Award of the Carcinode Neuroendocrine Tumor Society. The Distinguished Service Award of the Canadian Society of Endocrinology and Metabolism, an Endocrine Society Outstanding Abstract Award, and the Royal College of Physicians CSCI Distinguished Science Award, and the Endocrine Society Abbott Research Mentor Award, and the Novartis Senior Investigator Award of the Clinical Research Scientist, and the Gentle Giant Award of the Pituitary Network Association. We all know Dr. Ezzat is a very busy man getting information out there worldwide with his awesome knowledge. So I would like to introduce Dr. Ezzat.
Can you hear me okay? Excellent. Good afternoon, everybody. Deanna, thank you so much for the kind words, and thank you all for allowing me to be able to participate and to listen on to your conversations and your discussions. And I hope that I'll be able to add a little bit, and then perhaps we'll have a discussion afterwards. I titled my talk here, A Rational Socialized Approach to Managing a Rare Condition. And you'll see in a minute why I did that. And I'm going to tell you that my talk is really divided into several areas. I want to give credit to Canada for the good things that it has done to advance the understanding of many areas of medicine, including acromegaly. But I also want to highlight where that sort of gridlock is in knowledge transfer of how it's actually translating in real life down to the patients, and how you and the rest of the team can really help to try and bridge that gap and make things better. I have to tell you, I wrote a paper, and I just reminded myself as I was checking earlier, believe it or not, it was 1992, so that's 30 years ago. At that time, I had been looking after my 100th patient with acromegaly, and I figured, wow, I knew a lot. So I wrote the article, I said, living with acromegaly. Years later, I got married, and I got to learn that by definition, I don't know anything, and I can never really be an expert, because that's the definition of a good husband, is knowing that you can never really know anything. So with that in mind, what did we actually really do in Canada, and what is it that we've done right? A few years ago, first of all, I should tell you that despite the fact that this is a big country, they're relatively focused, because almost always it's really in the main cities that care is delivered. And you can see here the different universities that have come together to identify at that time 650 patients with acromegaly. Now, what we learned from those 650, I'm going to share with you Doesn't mean that's all we've got, but that's what we had at the time. And it illustrated some of the strengths and weaknesses, which I'd like to share with you, if I may, so we can see how we can do things differently. First of all, just to give you some idea, from 1980 to 1994, we had identified 169 patients that were being looked after across the country, where people could say medically, these are verified cases. From 95 to 2010, same 15-year interval, we had 470 patients. Now, that doesn't account, obviously, for changes in the size of the population, but just give you some idea of the feel for what was actually being diagnosed. Notice, and this is now more than 10 years ago, because this was published back in 2013, women speak up. So it tells us that if you speak up, you're far more likely to get diagnosed earlier than if you're a man, because men just like to put up and shut up, and they wait for a little bit longer until things really break down, until they say something. So it does pay. However, there is clearly a delay, and the delay in diagnosis is really very problematic. It's very problematic because you can see here, the vast majority of patients were still diagnosed in their 40s. And we still picked up patients even in older age. And this is something that I really want to emphasize. A lot of times people say, I'm just getting old. I've got arthritis, I've got diabetes, I've got hypertension because I'm old. That's not necessarily true. And just because you happen to be over the age, here, definition of age, I apologize, old meaning over 60. That's going to change in a couple of years from now. I'm going to make that 70. But for now, I'm going to go with 60, okay? The take-home message here is this is not a disease of just the young and the old, and it's not about men or women. It's about all of us. The important thing also is we noticed in our Canadian patients, because the Americans sometimes, the Americans, we don't necessarily always believe them because it's a different healthcare system. So perhaps the delivery and identifies things with a bias that's different than ours. The fact is, in Canada, amongst these 650 patients, diabetes was present in a quarter of them. 36, high blood pressure. High blood pressure that's enough to actually affect heart function. Sleep apnea. Sleep apnea. So I heard you guys talking a little bit earlier about sleep apnea. I do think this is a very important factor. None of these things, diabetes, hypertension, sleep apnea, these are very common in the population. But if you have them and you don't have really a very good explanation for why this bundle is coming together, perhaps, just a very 5-second checklist, it might say, why does this patient have all these things? I should also tell you, cancer here was accounted for mostly by thyroid cancer, but also colon polyps, which turn into cancers later on. So this is really what happens. This is the problem is, here's the person. This can be you, me, anybody else. And they walk through life. They see a primary care physician who checks and finds their lipids, because for some reason, lipids are really the most important thing, but it happens. And then they go on and they develop diabetes for whatever reason. And they see a diabetologist, which is great because this is Canada and you have access and it's all free. Then you see a respirologist because you've got sleep apnea. And then you bang your head, an MRI is done, and you get to see a neurosurgeon who takes out the tumor. And then afterwards, if they're lucky, they will have a pathologist who's going to look at that sample and say, wait a second, this isn't just a non-functional tumor that you guys told me it was. This is a growth hormone tumor. And then the diagnosis is made, and then we start to go on and on and on, and we see all these specialists over and over again. And it's a vicious cycle. And many of you probably recognize this kind of paradigm, perhaps a little bit different, maybe the box is a little bit different, but this is not a very efficient way of managing any illness. And it's not acceptable. What we also found is the vast majority of patients in Canada were getting an operation. And that's a very important distinction from other countries. Why? Because in Canada, if you bang your head and there's a tumor, we'll take it out for free. But if you need a medication, not necessarily. We'd rather operate on you. In fact, we'll give you radiation for free, but we're not going to pay for your medication necessarily. That's Canada. So we're different. We've got the good and the not so good. And you're not going to see this in the literature. People don't talk about it, but it's true. Is this the right thing? I'm not sure, but there's some of the things that you need to be aware of. Only about somewhere between 50 to 60% of patients that needed medical therapy were actually getting it. What's happening to the other half? Well, they don't have coverage. They're not being assessed properly. Perhaps the parameters or the indicators of whether they in fact need treatment or not are not necessarily being adhered to. That's a very, very big issue. It's a huge issue. Again, diabetes, heart disease, cancer, and it didn't matter because when we looked at big decades differences, heart disease was still there. You'd think that with the advances in other areas of medicine that we would make some real headways. We didn't. I'm telling you how it is. So what we did come to realize, and I truly believe now, that really the best way of understanding and thinking about acromegaly from a medical standpoint is that it's not about big hands and feet. It is about a syndrome, which means every organ of the body is in fact affected. In fact, I don't know of any part of a body that's not. From the heart, the lungs, the blood vessels, to the diabetes, to the physical changes that affect the joints. Having followed many patients now for decades, I have to tell you, one of the biggest things that I plead for when I'm trying to control the disease on many of the patients, it's not just about the hormone levels or where they are within the hormone levels, but I worry about their shoulders, the knees and hips, because you can get rid of the headaches, you can get rid of the sweating, you can normalize the hormone levels, but making sure that you've done it effectively enough to prevent this patient from requiring multiple orthopedic operations, that's a very different story. That's going to linger on, and ultimately it's going to affect what's shown here in the left-hand corner. That's quality of life. It's not just a matter of number of years. It's not a matter of survival, but it's that elusive goal of quality of life. And it's a very, very important thing. It is probably what it's all about. So treatment options, yes, Canada has been fantastic in making headways. In fact, I don't know if you guys talked about this earlier. Canada has made some incredible contributions, with Dr. Jules Hardy being one of the foremost to develop the technique of getting access to the pituitary from underneath. And we call it the Hardy's classification of tumors, which is great. We've also made tremendous progress in understanding the pituitary. In fact, the gentleman who first started pituitary understanding was in Canada. His name was Hans Selye. He happens to have been the mentor of Dr. Ezzat's mentor. Now, isn't that sort of really weird if you think about it? And interestingly, that gentleman, Dr. Selye, who came from Europe and was brought to study, he understood that the link between stress and the response to stress was in the pituitary. So we've got a long history of understanding so many things and contributing from Canada towards really improving knowledge across the world. And we now appreciate, and I'm sure Dr. Ezzat has done a tremendous job at telling you of how we understand now the different types of tumors, of which the pituitary is a member of that family, and how recognizing that information is really going to facilitate so many aspects, from the scientific to the clinical to the access, and recognizing that the infrastructure of all endocrine tumors has a common denominator. And that's why the pituitary has to belong within a family. It cannot be orphaned. And one of the things that I'm going to get across today for discussion is that acromegaly and pituitary disease cannot be left out. It is part and parcel of the entire body and it includes a larger family of endocrine tumors. And those of you who may, in fact, even know of individuals we call multiple endocrine neoplasia. That is a disorder recognized for its pituitary involvement, as well as other endocrine tumors, including the parathyroid and the pancreas. We can talk about that later. But here's one of the biggest pitfalls, and you guys are probably going to consider this in your deliberations. This is the textbook description where a lot of endocrinologists really get hung up. They recognize that the pituitary makes growth hormone, and they recognize that this circulates in the blood to stimulate the liver to make IGF-1. We all know that. But that's just the beginning. That's really scratching things at the very surface, because when people come back and they say, I'm not entirely well, I had my tumor removed and you can't see it on the MRI anymore. I've done my blood test and it shows values that are largely normal, but I'm still not feeling great. So what the heck is going on? Some doctors will say, it's in your head, so to speak, or maybe you have something else. Well, the truth is not quite, because there's a huge area of medicine that we really have trouble with, even on a scientific level. And that is, what we measure in the blood is only one window, one very small window on the big picture. Why? Because all tissues, as you can see here, whether it's the liver, the fat, muscle, or bone, they all have receptors for growth hormone. What's happening within the tissues is not always reflected by what's happening in the blood. And indeed, the ability of IGF-1 in the blood to give us an accurate picture of everything that's going on is somewhat limited. Now, I don't want you to misinterpret this by saying, well, the blood tests don't mean anything, Dr. Ezzat, so what's the point? That's not the case. All I'm saying is that to be able to understand the big picture, you have to stand back. You got to listen to the patient. You got to listen to where they were, where they are, and appreciate the limitations of the tools that we have, and recognize that there are lots of normative values, and there's a lot that we still have to learn. And we've got to acknowledge this, and we have to be able to appreciate that on the medical side and on the population patient side. And we got to be able to communicate honestly and openly about these limitations. Let's not take extremes. And I don't want to hear about people having to go and get the hair levels, because obviously some of us don't have any hair left, but you can measure growth hormone in that. That's quackery. We don't want to get to that, but we do want to appreciate that there is a lot that's still to be learned, and there are, in fact, scientific basis for these discrepancies. The other thing that we haven't, and Dr. Ezzat may have talked to you about this, is why the heck do some tumors grow sideways instead of up? Everybody is, will tell you that tumors grow up and they press on the optic chiasm and you lose your peripheral vision. And if you don't have that, then you don't have a pituitary problem. Well, guess what? One of the things that happens with even the nastiest growth hormone tumors is they decide to grow sideways. And they envelope themselves around this black hole here. I hope that my marker is showing. This black hole is the main blood vessel, the carotid, that supplies blood to your brain. So the neurosurgeon, however great they might be, they can't get into that cave. That cave is called the cavernous sinus. That's why a heck of a lot of patients end up with persistent disease, despite the best operation. And one of the reasons why these tumors grow sideways is because that's where growth hormone cells are most likely to be represented within the gland. They sit in the side. So one of the more, shall we say, typical features of a growth hormone tumor is actually grows sideways, not upwards. So medical school student teaching was not accurate. So what do we do? What do we do about the healthcare system? How do we apply it to something like acromegaly or pituitary disease for that matter? Well, this is a paradigm that I sometimes use in trying to communicate with some of my colleagues who argue with me, and they say, come on, you don't want to cause harm. Well, in medicine, we recognize that there's a spectrum. And the spectrum here is shown on the green line, where what we like is to be able to do good. We don't want to be in the red line. Red line meaning that we're doing harm. We want as much as possible to be able to improve the patient's outcome with the lowest amount of risk. This is a principle that applies across the board. And really what it does is it means that we have to be able to look at every patient and recognize where they are within that continuum of risk of progression. How bad is the disease really? How good is the intervention? And are we in fact getting closer to the green line where we're doing more good and less harm or not? That's the main principle. But we don't always do that because we're not always successful. We want net benefit, and we want to do it in a fiscally responsible manner because we want the governments to be able to support our socialized system. We don't want to go bankrupt where we're causing harm at great expense. So I want to leave you with this particular slide here. We want to be in the green side. We don't want to be in the red side. And that requires a lot of thought. And it requires a lot of consideration and efforts. We're going to talk about these. One of them is to be able to recognize what tools to use. So when a patient comes in and they say, I'm tired, and the doctor listens to their heart and checks their blood pressure and checks their blood tests and everything looks great. Well, one of the things that does happen is, and specifically with acromegaly and many other hormonal conditions for that matter, is that the heart thickness does not allow for the heart to empty and relax properly. And that is something that's actually measurable. And it's measurable along a continuum, but very few endocrinologists do it. Because they say that's the cardiologist. And the cardiologists, all they see are patients with heart failure. So there's miscommunication. And yet we have the tools to be able to see within that risk continuum I was talking about before, where's that patient? Is their heart really perfectly normal or is it not? Is this patient's complaint related to the fact that their heart is no longer functioning optimally? And can we in fact do a better job? Guided by the blood tests, guided by other studies, including those of the heart. And I will argue that the heart really is, no pun intended, at the center of what makes people feel unwell and that we don't do a very good job. This is one of many other examples where we don't really do a very good job. So the goals of therapy need to go beyond just normalizing hormone levels and reducing the size of a tumor, which we do. But that's just the beginning, guys. That's the basement. There's a lot more. And as such, we need to do a better job. And I think that one of the things that we can do, taking advantage of the strength of Canada as a socialized system, is that we need to be able to capture patients. We need to be able to cohesively identify as many of the patients across the country as possible. And I'm going to tell you about some of the techniques to do that. We do know that patients get operated on, but what happens to them after that? Many of them get tested. Some of them don't. Some of them get tested on a regular basis. Some of them don't. Some of them get a glucose tolerance test. Some of them don't. There's a lot of inconsistencies. Not everybody is getting the same treatment. Medical therapies. To what extent are the different classes of drugs, from oral to injectable to a variety of other medications, to what extent are these being used appropriately when needed, or when they're not needed, or when they're not appropriate? But I will tell you, in Canada, we've done some good things. And this is one example of, and Dr. Johnson, who's sitting in the audience, and others have actually contributed to this paradigm where we, unlike the Americans, have said, you know what, we can actually come up with something better. We can say, based on the type of tumor and the appearance on the MRI, we can stratify what the likelihood is that the patient is going to respond to one line of treatment versus another. In other words, it's not a hit and miss. Be guided. And the Americans actually were not very happy with us when we proposed this. And it took us a little bit of time to publish it, but we did. And then the Europeans started copying us. Yeah, they copied Canada. But we can do more. We can do a lot more because the seeds are there and the Canadian system has a lot that can be taken advantage of. And that's why I think that the registry across the country is very important. Now, I want to emphasize here, the idea here is to be able to have patients report the information, French speaking and English speaking. Obviously, we want them from across the country. Why? Because we want to know about those areas, not the guys who are living in downtown Toronto or downtown Vancouver, but I want to know more about what's happening in the underserviced areas. Where are these patients? How are they getting care? To what extent are they getting what they really deserve and what Canada truly can offer them? So there are challenges, as I pointed out, and access to the treatment options is there, but the opportunity here is to be able to do it online, hopefully, whether this is the patient himself or herself or with the assistance of others. But really what I'd like to be able to see is have more people come forward. And I'm going to give you the website address so you can see that it's an opportunity for patients to enter the information anonymously, to be able to allow for a more cohesive understanding of what's happening across the country, as diverse as the population is and healthcare delivery. And what you're going to be able to see is that when you go on, it's called acromegalyregistry.ca. You're going to have that shown on the last slide. I'm going to leave it a little bit longer, but you're going to be prompted to be able to create your own account anonymously, enter your information, have as much of it with you as you can. And believe me, it's a lot better than COVID and coming back into Canada. This is a lot easier, a lot more user-friendly, a lot more worthwhile too. But importantly, what I want to be able to recognize here is it is a team. And it's not a matter of one side or the other. This is the whole team. It's a team of the patient with the physicians, the surgeons, and I should indicate here that truly the nurses play an absolutely critical role here. And a well-experienced nurse, I would say, is probably pivotal in making this team work and continue to function, not just on a one-time or once-a-year basis, but on a continuous basis. But I think we can do more, because if we can put our heads together and if we can communicate together, this is how I think that you can become more involved. You can have your say. And again, here's the website. You'll be able to register. And I'd like to hopefully be able to come back to you in another year or two where we can look at this data in aggregate. You're not going to be compromising any of your information. You don't have to worry about being denied your insurance because all of this is anonymous. Your spouse will not find out whatever it is you don't want to share with them. But the important thing is that we got to be able to do it better. And I think that we can communicate better and hopefully be able to take advantage of what Canada does in fact offer to its patients. But so far, we haven't quite taken full advantage of it. So I'm going to pause at this point. I really want to thank you again for giving me the opportunity to be able to share with you at least some of my experiences. I think it's a mixed message. Hopefully it's one that leaves you with some hope, and it gives us an opportunity for a dialogue. And I'm really very excited to hear what you guys have to say, and looking forward to your questions. Thank you so much for your attention. Thank you.